Hello class and Dr. Kemp. Here is our week 11 discussion post. We have a 65-year-old non-binary patient with a past medical history of heart failure and stage renal disease with dialysis Monday, Wednesday, Friday, type 2 diabetes on insulin, hypertension, CAD status post-PCI, aortic stenosis and AFib on warfarin, who presented to the hospital with shortness of breath. She denies missing any dialysis, and she has not had any appropriate cancer screening. She has lost a significant amount of weight over the last couple of months, and she does report a history of smoking, mild alcohol use, but no illicit drugs. So first, we're obtaining an informed consent for thoracentesis. So how I would present this to the person is, good morning, my name is Natalie Franco, nurse practitioner, and I will be performing a left-sided thoracentesis using ultrasound guidance to remove the fluid you have in your left lung. Thoracentesis is indicated for the symptomatic treatment of large pleural effusions. This procedure carries risks which may include infection, bleeding, subcutaneous hematoma, injury to the lung, pneumothorax, hemothorax, laceration of the liver or spleen, diaphragmatic injury, pain, cough, or tumor seeding. Advantages of this procedure is minimizing symptoms and proper diagnosis of why you have this pleural effusion. A sample of the fluid will be sent to pathology for examination to determine if the fluid is infectious or cancerous. To describe the step-by-step procedure to this patient, I will explain to the patient that this is a standard aseptic technique is used for this procedure. A white area is cleaned with ChloraPrep, and then a sterile drape is placed over the puncture site. The skin, subcutaneous tissue, rib, peristernum, intercostal muscles, and pyrochlora will be infiltrated with lidocaine 1% or 2% for local anesthesia. The skin is then nicked with a number 11 blade, and then with aspiration initiated, the needle is advanced over the superior aspect of the rib until pleural fluid is obtained. The catheter is then fed over the needle introducer. With either a syringe pump or a vacuum bottle, the pleural effusion is drained until the desired volume has been removed for symptomatic relief or diagnostic analysis. The catheter is then carefully removed and a dressing is placed over the puncture site. I will also let the patient know that one should not remove more than 1,500 mLs of fluid during a single attempt, as it can lead to re-expansion pulmonary edema. The fluid will then be sent to pathology for analyzing. For question number 3, what should we consider prior to the procedure regarding the patient's past medical history? So according to our reading, there is no absolute contraindications to a thoracentesis, but there are some relative contraindications, including bleeding disorders or anticoagulation, which this patient is on warfarin, altered chest wall anatomy, cellulitis or herpes zoster at the puncture site, pulmonary disease severe enough to make complications life-threatening, or uncontrolled coughing or an uncooperative patient. How would you differentiate between exudative and transudative pleural effusion? So according to our reading, Krishna and Rudrapa, pleural fluid is classified as a transudate or exudate based on modified Light's criteria. Pleural fluid is considered an exudative effusion if at least one of the criteria is met. So those criteria are 1, pleural fluid protein serum protein ratio of more than 0.5, pleural fluid lactate dehydrogenase, or the LDH ratio of more than 0.6, or number 3, pleural fluid LDH is more than 2/3 of the upper limits of normal laboratory value for serum LDH. Common causes of transudates includes conditions that alter the hydrostatic or oncotic pressures in the pleural space, like congestive heart failure, which the patient has, nephrotic syndrome, liver cirrhosis, hypoalbuminemia, leading to malnutrition, and the initiation of peritoneal dialysis. Common causes of exudates include pulmonary infection like pneumonia or tuberculosis, malignancy, inflammatory disorders like pancreatitis, lupus, rheumatoid arthritis, post-cardiac injury syndrome, cyclothorax, hemothorax, and benign asbestos pleural effusion. For question number 5, did this patient experience any bias or barriers that could have impacted their health outcome? In my opinion, the patient did not experience any biases or barriers that could have impacted their health outcome. This patient was treated for their pleural effusion accordingly and was fully evaluated for proper cancer screening due to the symptoms that she was exhibiting. My two open-ended questions are: what are indications and contraindications for chest tube placement, and describe how to properly place and remove a chest tube. Thank you, and I hope you enjoyed my post.